So is knowledge of the venous vascular anatomy clinically relevant? The answer is obviously no. Yes, the answer is yes, of course. So here we have a patient with meningioma, false meningioma, looked to be pretty benign. And in a few years' time, this patient developed symptoms and the meningioma was enlarging, so it was deemed to be appropriate to remove the meningioma. But after the surgery, the patient initially did okay, but then started worsening neurologically, and then CT was done and showed a large area of hemorrhagic infarction. And eventually, with worsening of the condition of the patient, it required a decompressive surgical intervention. So here we have the sequelae of what should have been a very predictable good outcome became a disaster because of the apparent sacrifice of the venous drainage in the region. And so therefore this always, most surgeries, as you know, get away with interference of some of the veins, the cortical veins, because there's such a good anastomotic network. But in certain cases, like in this case, it turned out to be not the case, and a disaster sort of occurred. So let's look a little bit more in detail about the supratentorial venous vascular anatomy. We're going to look at the deep venous system, the transrenal veins, which most people haven't heard about, and the superficial venous system, the cortical venous system. As you know, originally, and we've gone over this multiple times, the initial supply to the central nervous system is the choroidal supply, which comes from the anterior artery and the anterior cerebral artery that supply the choroid plexus. And as the brain enlarges, of course, the additional arteries become relevant and important. And the initial choroidal system drains into the median prosencephalic vein. And that includes the drainage of the intercerebral veins in that location. So that's at the 7th or 8th week, the choroidal plexus drains into what it will turn out to be a temporary midline vein, the median vein of the prosencephalon. But then something happens. There is a rearrangement of the area, and the anti-aspect of this median prosencephalic vein actually regresses, and the internal cerebral veins find a new outlet beyond that, and the internal cerebral veins also take up the drainage of the choroidal system. So the choroidal system now drains into the internal cerebral veins and then into what now has been called, or will be called, the vein of Galen, which originally was in the same region as the median vein of the prosencephalon. Now, so now we have, if we start looking at the deep venous system, we have its tributaries and we have its territories and the exits of these veins. We're going to look at them. Obviously, it's draining most of the deep the structures of the brain, the old brain, the thalamus and the basal ganglia region. And with the vein of Rosenthal, that is part of the deep venous system, although it drains also cortex, it shows its domain, its territory to be the midbrain and all the way medial temporal lobe and inferior frontal lobe region. So we're going to look at the various battles that can occur. MRI is incredibly good in showing the venous system, especially if you use 3 Tesla and SWI. And you can see how beautiful these veins, the thalamus striate veins, the septal veins, the atrial veins are shown on search imaging. Much nicer than on angiography that we used to use in the past to look at it. But we could see with angiography, we could see the variability of the tributaries to the internal cerebral vein, with the thalamus striate veins draining in various locations, entering the internal cerebral veins. remember always, and Philippe will tell you that one more 1,000 times, that the thalamus drive vein does not drain the thalamus, although the name has been given as if it seems to be draining the thalamus, it does not drain the thalamus. So thalamus drive vein drains above the thalamus. Okay, so this is what we can see, and sometimes we see variations of that. We see the internal cerebral vein actually has an increased territory beyond its normally expected territory, and we see an extension of the thalamus drive vein because of the absence or poorly developed superficial system. The thalamus drive vein in this case drains a larger territory. We get to the phenomenon of DVAs later, but you can see some examples how the territory, the expected territory of the internal cerebral vein is way beyond its normally expected territory, but involves almost the entire hemisphere, as in this case shown with the SWI imaging. Which also means that the internal cerebral vein becomes very much prominent in appearance, enlarges in size. You see the relatively absence of visualization of the cortical venous system that have poorly developed. So this transcerebral venous drainage towards the internal cerebral venous system is nicely shown in cases where there is a problem on the cortex of the surface of the brain, where there is venous thrombosis, and the blood has to come out and goes right through the brain itself and goes towards the deep venous system. So the internal cerebral vein can drain a much larger territory using the transcerebral venous system, as in this case is shown. The transcerebral venous system is also shown on MR. You can see how these vessels actually, you can see them nicely projected onto these images. So look for them, because it may indicate an abnormality. It may be too prominent, and therefore there is probably a reason for it to be so prominent, and it can explain clinical symptomatology if the pathology involves the superficial system or the deep venous system, obviously. In this case, there is we don't see any deep venous system. The internal cerebral vein are missing in action. This can, of course, be in acquired venous thrombosis, or it can be in hyperpressure in the venous system from a dural shunt or brain AVM. In this case, we see there is an absence, and now the blood drains out through these transcerebral veins and draining towards the superficial cortical venous system. So this transcerebral venous system is very helpful in multiple ways. It can be enlarged in DVAs, or it can be enlarged in certain diseases such as venous thrombosis. It's the same patient. You can see there is no deep venous system. This is cortical system. This is vein of Brugge. It's not a straight sinus and not a vein of vena. And you can see under these circumstances these black dots. Those are veins coming straight at you from the depth towards the superficial cortex, and it has this very typical appearance at angiography. So let's look a little bit at the internal cerebral vein at its exit channels. Where can it go to in various circumstances? And here you can see the internal cerebral vein, the deep venous system, is draining through the usual, what seems to be the usual vein of Galen and straight sinus, but then there's a parallel channel that also takes up blood from the deep venous system. And here you can see how the internal cerebral vein is not draining to the vein of Galen at all, but it's actually draining to the falcine dural sinus and out and down the superior sinus. So this is often seen in patients with vein of Galen malformations. This is rerouting, but you can see this is, in this case, was not symptomatic, no vein of Galen malformation, but it's purely a rearrangement of the distal exit route of the internal cerebral vein. Here the internal cerebral vein is draining into a parietal vein, medial parietal vein, and out towards the superior sagittal sinus. So there's a variability in the outer and the way the internal cerebral vein and consequently the deep venous system can drain, and you should be aware of that. Here is a patient which is a typical configuration that you see in patients with venous gain malformations. This drainage pattern behind the thalamus to the lateral mesencephalic vein towards the petrosal venous system. You can see the petrosal sinus. You can see the lateral mesencephalic retrothalamic to the internal cerebral vein. So you can, another way out. So we've seen out through dural sinuses, through parietal veins, and this to the posterior circulation, venous system. Now let's look at the other component of the deep venous system, which is the basal vein of Rosenthal. This is the basal vein of Rosenthal, internal cerebral vein, vein of Galen. And we're going to look a little bit at Philippe's favorite venous system, which is the circle of Willis, which is part of the tributaries and anastomotic channels of the vein of Rosenthal. Vein of Rosenthal courses around the mesencephalon, the midbrain level, communicates at the interpeduncular cistern level between left and right, and communicates anastomosis between the left and right side at the anti-communicating vein level, which is above the level of the chiasm. We're going to look at that now. So this is the normal environment, the vein of Rosenthal in the normal environment, and it takes up tributaries from the medial aspect of the hippocampus and temporal cortex region. So although it is called deep venous system, it does drain actually cortex, and it drains the adjacent midbrain and cerebral peduncle region. Tributaries extend forward towards the inferior posterior aspect of the frontal lobe cortex. So it's in quite a large territory that the vein of Rosenthal actually drains and encompasses. In case there's a clot within the vein of Rosenthal, this is what it looks like. You can see in this case. And to get a better feeling for what the territory is that it drains, is shown in this patient with thrombosis of the left side, the vein of Rosenthal. You can see the medial aspect of the temporal cortex and the inferior aspect of the frontal lobe, posterior aspect of the frontal lobe cortex, as well as the adjacent midbrain region. So it shows quite an extensive drainage territory. So a little bit more, because most of us are not too familiar with this venous circle of Venus, and so we're going to look at examples and the presence of this circle of Venus, as is shown on this diagram. So the anti-communicating vein, representing an anastomotic channel between the tributaries of the anterior aspect of the basal vein of Rosenthal, shows on the specimens from Philippe, shows very nicely the forward extension towards the frontal lobe cortex and the posterior extension towards the temporal lobe and eventually the usual around the midbrain level. So we're talking about a channel that is located above the chiasm and above the anterior cerebral arterial system. And you can see on CTA, you can see this vessel. On the coronal pictures, you can see the A1, A2, but you see beside it and above it the communicating vascular structure, which is actually the anterior communicating vein that crosses over from left to right. It can be asymmetrical, it can be, of course, draining from both sides, more towards one side or the other, or it can be more symmetrical in appearance, and it is, as I said before, located at the level of the chiasm, between the chiasm and the brain itself. It can be used for brain AVMs to drain across the anti-communicating vein, and you can see as in this case, how it creates sort of congestion in the region and allowing blood from the left side of the abnormality to drain to the right side of the system, explaining sometimes why symptoms on one side can be created by a problem on the opposite side. So here we have the posterior communicating vein. It's at the level of the interpeduncular cistern. It collects blood from both sides, obviously, and from the adjacent midbrain level, and it anastomoses with and drains potentially the cortex of the inferior posterior frontal lobe. You can see again the communicating vein at the level of the interpeduncular cistern between the left and the right side. But sometimes you can see that on one side actually drains across this posterior communicating vein towards the opposite side. And so you can have, if there's a problem with this vein further downstream, then it will express itself as clinical symptoms on the opposite side. So always be aware that veins can do that. Veins are very capable of giving you false information as far as the location of the abnormality versus the clinical symptoms is concerned. So again, this is the posterior communicating vein draining or communicating anastomosing the tributaries of the venous rositale on both sides. You can see it here. And this vein can also be seen on CTA. So if you look on the axial and sagittal images, you can see this vein is just behind the tip of the basilar artery and at the level of the interpeduncular cistern. On the coronal images, you can see it crossing the midline and going down towards the petrosal venous system. So you can follow it all the way through the lateral mesencephalic communication all the way to the interpeduncular cistern level where the posterior communicating vein is located. So it can certainly be seen on imaging on CTV and CTA. It can be congested if there's a brain AVM or dual shunt draining into the region. You can see totally an outline of the entire system and its tributaries, including the posterior communicating venous system. And as I said before, it may explain why symptoms occur. This is a brain AVM, it's presenting with pulsatile tinnitus on the left, and you can see the brain AVM is on the right side, but it drains across this posterior communicating vein towards the opposite side and then towards the region of the Peters bone, creating the symptoms. So brain AVM crossing over, and going eventually end up creating symptoms related to the drainage across the posterior communicating vein towards the opposite side. Bless you. We should also, just like we did with the internal cerebral veins, we should look at exits of the venous rositale. By far the most common one is of course towards the junction with the internal cerebral vein at the level of the vein of Galen. But not infrequently we see that the venous rositale drains differently and uses a persistent dual sinus at that level, and you can, and we'll show you some examples of that. So of this transtentorial drainage. So here's a brain AVM in the Sylvian region, and it's draining forwards. It's going towards the normal appearance of the location of the venous rositale, draining backwards. But now you would expect it to go up towards the vein of Galen region, but in fact it drains through the tentorial sinus, which is usually bowing up slightly and bowing out slightly. It is a very typical configuration of a tentorial sinus. So in this case, the exit from the venous rositale is the persistent tentorial sinus. The group of Karel and Utrecht has paid a lot of attention. As you know, they named the term perimesencephalic bleed, and they looked at the veins in the region in patients with perimesencephalic bleed, and they found an increased incidence of venous anomalies. And one of the main ones that they found frequently was the vein of Rosenthal draining in this tentorial sinus. So venous anomalies perhaps could be related in some way to perimesencephalic bleeds in the region. Again, you see this outward bowing tentorial sinus, this upward bowing on the sagittal view, typical for a persistent tentorial sinus draining the vein of Rosenthal. Anastomosis from the supratentorial and infratentorial system, or the deep venous system and the posterior fossa system, is through these lateral mesencephalic veins. Very important venous structure that allows drainage of the deep venous system, including the vein of Rosenthal, towards the posterior fossa circulation and through this collateral anastomotic channel, reaching the petrosal venous system, the petrosal sinus. In this case, again, you can see the drainage of the deep venous system is not in the usual way to the vein of Galen and straight sinus, but is actually going down lateral mesencephalic and down beside the brainstem, and you can see this lateral mesencephalic vein, medial lateral mesencephalic vein, and you can see its drainage pattern and its communication with the Peter's sinus system, or it can keep on draining along the brainstem all the way out at the posterior, at the condylar level. These veins can be altered and rearranged by surgery, and in this case it shows after posterior fossa surgery a very prominent anti-perimedullary venous system that communicates upwards towards the petrosal vein, nicely shown here. And so the venous system, because of its naturally present anastomosis, can quickly redirect itself, compensating for what otherwise would have been a catastrophic situation. Okay, we go from the deep venous system to the superficial system. As you know, again, the variability of the cortical veins is enormous, and therefore it is difficult to predict which situation there will be consequences as far as approaches is concerned. But the one thing that allows surgeons to get away with interference of these cortical veins is that there is many anastomoses between the systems. And you can see here, between this cortical vein and this one, there is nice, and the sylvian vein, there is nice anastomotic opportunities, and that will allow blood to flow one way or the other. So it's not always creating, fortunately, it's not always creating a problem. Again, you can see in this situation, there's multiple equal in size cortical veins, labae to line, that are communicating with each other, allowing for, if one of them were to be sacrificed or involved with disease or by surgery, you can see there will be ways of getting out of the region without creating venous ischemia. But the more asymmetrical things get, the worse things will become. Obviously, very prominent tumor, and now there still seems to be good collaterals at the proximal aspect. But if you look at this labae vein, it's not really connected anymore to any of the upper venous systems. So if something happens to this vein, there will be a wide impact, right? There will be a huge venous type of infarction. So it is completely unpredictable, of course, what we're dealing with. And if our surgeons have started to ask superimposition of the venous system on the brain to see the relationship between the possibility for venous anastomosis. At the post-fossa level, you can see very nice petrosal venous system draining the deep venous structures of as well as the vermian vein venous system, all nicely shown and in balance with each other. But you can also see that just like upstairs, there is, in this particular case, there is almost no cortical veins, and so everything is draining deep. In this case, same case, the deep venous system represents the only way out, and this is obviously vulnerability. If something happens under these circumstances to the draining vein, we have a huge infarction. A few words about the dural sinuses. We tend to think of them as a separate structure and rather not very interesting, but in reality, the dural sinus is has become more and more of interest in various clinical conditions, and we'll mention them in a moment. It's rather surprising that we don't see more problems at the level of the dural sinus, because as it develops simultaneously with three different phenomena. So there is the initial coalescence of multiple parallel channels at the level of the dura, which eventually become, in nearly everybody, a single dural sinus, but we may have persistence of parallel channels, and that may be the drainage of dural shunts that only drain in one, but not in both channels, and you have to make sure that you occlude the proper one and not the wrong one. So there is this evolution of multiple parallel channels towards a single draining pipe. That's one thing that's going on. At the same time, this single draining pipe eventually will start collecting the bridging veins from the cortical venous system, so that has to be integrated. And at the same time, we see the extension of the CSF into the venous system, the dural sinuses, through the pachyonian granulations. So all these things are happening simultaneously, and it is really remarkable that we don't see more often sequelae going wrong and the sequelae showing up in clinical conditions. One of the evolution and the maturation of the dural sinus starts at the level of the torcular and goes forward and goes downward. So this is where it starts. And you can see in this case the dural sinuses initially have multiple shapes and forms, while eventually it becomes the simple outline that we are familiar with. But if things go wrong, then at the level of the sinuses, you can see as in this case, in 22 weeks gestation, there's a mass effect. The mass effect is actually a partially clotted dural sinus. Because there's an enlargement of the dural sinus, the flow of the blood is decreased, and there's an increased chance of clot formation, and this will eventually be not compatible with life in most situations. We also have to remember that the veins are not cooked when you're born. They keep on being progressing, and so the veins up to about age 2, when they finally reach their final maturation adult type of configuration. So there's an ongoing evolution in the shape and size of the dural sinuses after birth. You can see the suboccipital sinuses have disappeared in the same patient a few months later. The dural sinuses have taken a different appearance a few months later. So there is remodeling, regression of the dural sinus that goes on up to age 2 approximately. Again, the patient has a vein of gain malformation showing this triggering factor, and initially at age 1 week, the dural sinuses and dural bulb region are pretty normal, and everything seems to be okay. But 1 year later, and associated with clinical symptomatology, we have now lost the transverse sinus on one side. We see progressive narrowing on the opposite side, that things are not going in a good direction. So this progressive maturation can be impacted by diseases and will have consequences. The other thing to remember is that the cortical venous system of the brain and the cavernous sinus do not communicate till shortly after birth. So the system that the veins that drain the eye and the nasal fossa into the inferior sinus region are not communicating with the cavernous sinus. So they are two separate systems, and this is very important because this communication is needed badly when you have abnormal situations such as dual sinus shunts and vein of Galen malformations, where the blood has to exit somewhere, and if the exit at the vein of Galen region is physiologically blocked because of the hyperpressure, the cortical blood and the deep blood has to go somewhere, otherwise the patient will die. And therefore this communication at the cavernous sinus region, the cavernous capture of the cortical veins, becomes a life-saving and very important phenomenon. So initially that doesn't exist, but it will occur. If it doesn't occur, there is a problem, obviously. And you can see this is a persistent embryonic vein that drains the sylvian region, perisylvian cortical region, and you would expect it to hook up to the cavernous sinus, but it doesn't. It drains out towards the transverse sinus region. There's also in the same patient the persistence of the tentorial sinus, as you can see. So all kinds of variations, but the bottom line is no communication between it, the cortical venous system, and the cortical veins of the brain. There's an absence of cavernous capture. We're lucky to belong to a group that was very keen on vascular imaging, non-invasive vascular imaging using CT and MRI. And Richard Farbenard was one of the leaders in this aspect, looking at visualization of the venous system using MRI technology. And he was very keen on, if you really want to see it properly, you have to do contrast-enhanced MRI imaging, as opposed to what many people do is this time-of-flight type of imaging, which gives you all kinds of chances of misinterpretation of findings that are clearly shown to be normal at the time when you use contrast-enhanced in the same patient. So the veins, the cortical veins, and Philip will show you that also enter the bridging veins, enter the dual sinuses in a forward angulation and anti-angular angulation. So that will be important for navigation of catheters coming in through the supraesophageal sinus. And you want to go into a cortical vein, you have to make often a sharp degree of angulation. So that's one thing to remember. The entrance is not a purely 90-degree type of thing. And the MRI contrast-enhanced imaging will show you very nicely the configuration of the sinus, in this case draining towards one side, while the deep venous system draining towards the opposite side. And if you're interested in navigation from one side to the other, you can see there are actually channels between the two, and therefore you can cross over from one side to the other, despite the fact that the main channels seem to be separated in this case. When you don't see a sinus, a dual sinus, or a component of the sinus, you wonder what's going on. Is it filled with clot, or was it never there? And as we said before, the same rules apply. If there is no visualization of the lumen, then look in the adjacent structures, and they have compensated for that by enlarging. And so this is a congenital situation. This is not an acquired situation. And you can see how the venous system managed to cope and create a non-symptomatic abnormality. But in other situations, you don't see the supraesophageal sinus, and the reason you don't see it is because it's filled with clot. transverse sinus, supracentric sinus, different aspects of time of clots within the transverse sinuses. So again, MRI is very useful not only to show that there is no sinus, but that it's actually filled with clot in this particular case, explaining the clinical symptoms. And look at this mess, and look at this excellent evolution after giving proper anticoagulation therapy. 6 weeks later, you see the whole sinus has reconstituted, infield sinus, deep field structures, everything has in the transverse sinus, everything has reconstituted, including resulting in clinical improvement. So this is the contrast-enhanced MRI venography is a beautiful way of following these patients with venous thrombosis. So we looked at it, the role under those circumstances, and the visualization of dual sinus is best accomplished with contrast-enhanced MR. It's highly sensitive and specific in the demonstration of congenital versus acquired dual sinus abnormalities. And as you know, the two conditions that in the last few years have got a lot of attention are intracranial dual sinus hyperpressure and hypopressures. And so changes in appearance, variability in size, can depend on the intracranial pressure. So we used to think, I used to think, that these dual sinuses are rigid structures and they don't show much in the way of response to anything, but this is absolutely not true. So here in this case, now we'll see if we can manage this. So the normal appearance of the dual sinuses at the level of the transverse sinus, for instance, is this. It's equal in size on both sides. But in patients with idiopathic intracranial hypertension, there is flattening of the dual sinuses on both sides. If you have it on one side, it is not associated with intracranial hypertension, but if the flattening and narrowing is on both sides, it is. And so this is a marker, and a very reliable marker, for idiopathic intracranial hypertension. Now let me see if I can make this actually work. Yes. Okay, so you can see a flattening of both sides, right? And depending on the emulation, you may not pick it up at all. It may look on the AP projection okay here and not okay here. But if you turn it around, you can see there's a very severe flattening in that location. So it is important to look at these and make the effort to look at it in 3 dimensions. And in this case, it's a very typical appearance in addition to other things. But this is very typical for patients with idiopathic intracranial hypertension. And if you look at these patients before treatment, let's say they put a shunt in to diminish the pressure, you can see the flattening before, and afterwards you can see the reconstitution of the normal caliber size of the dual sinuses on both sides. Yeah, so there is a real response to the pressure. The reason is, of course, brain cannot increase or decrease, and so increased pressure, the only structure that can be responding are the veins, and therefore if the pressure is high, the veins will be compromised, including the cortical veins, but certainly the dual sinuses. So idiopathic intracranial hypertension, there's again Richard described this very nicely in this additional signs that I'm not going to show because of lack of time, but the bottom line is it's MRV is contrast-enhanced MR is a very nice way of making the diagnosis and following these patients in time. Now the next thing that lately, because of embolization techniques being applied, has been the entity of intracranial hypotension. So in hypotension, decreased intracranial pressure, the veins become juicy, become fat and prominent everywhere. And if you treat the patient by blood patch or by endovascular technique or surgery, you will see how these veins completely collapse. They become normal size again compared to before. So again, the venous system is very nicely shown to respond or to be responsible for pressure changes that can occur in various circumstances. So changes in intracranial pressure can impact the size of the intracranial dural sinuses and cortical veins. Reversibility of apparent dural sinus size can be demonstrated in patients treated for intracranial hyper and hypotension. And then finally, the last slide. The venous system, similar to the arterial system, is coming from the back and from the neuroectoderm and moves forward. And as it moves forward, there can be hits and triggers, as Timo showed you, making, if it's an early phenomenon, then the entire venous system is involved on one side. If it's late, then it's maybe just a phase. But in this patient, there's a venous vascular malformation of the facial region. You can see the intracranial circulation is not normal either, right? So there's DVAs and cavernomas, so all kinds of venous abnormalities that are coincidental with the venous abnormalities in the face because of the migration of the venous cells and the endothelial cells across from the back to the front, and at various periods of time they can be interfered with, creating metabolic diseases. So the intracranial venous system, there's an ongoing maturation of the venous system after birth. So that's important, that you're not done yet with the veins at birth. They keep on growing, they keep on maturing and changing caliber and size. The persistent anatomical variations may create unexpected venous territories. We talked about DVAs a bit, we'll talk about it more this afternoon. Changes in caliber in size and dural sinuses and veins will occur with different intracranial pressures. And venous malformations represent a spectrum of disorders that can occur in the metabolic distribution, as I showed you in the last slide. Thank you. Questions?